Hi guys, welcome back to Scanning the Mind. On this episode, we have a very special guest. I'd like to welcome Dr. Akshara. Now, as you know from our previous episodes, we're going to be speaking to different doctors from different specialties, and Dr. Akshara is here representing the GP world. Can you tell us a little bit about who you are and where it all began?
Yeah. So, as you said, my name is Akshara. I am a St2 GP trainee, and I'm currently working in Stockport. I didn't actually go to university around here. I went to uni in Leicester, which is a great uni.
Yes. Ignore
the faces. Yeah, so I didn't want to stay around Leicester. I wanted to come back up to Manchester because I've grown up around here.
Okay.
So
yeah, you sound like a proper Mancunian.
I used to have a really strong Mancunian accent.
At first I thought, have we got H on the show?
I came back up to Manchester because I grew up around here, my family's from here, and I did my F1 and F2 in Preston and Chorley.
Okay. Are they quite big hospitals or they're quite small?
Preston's fairly big, it's got a trauma centre.
Right.
Chorley is definitely smaller, but you kind of, do the jobs across the two, and I think it's a pretty good experience all around. The size of the group was quite small, so it meant that you got to know each other really well. You kind of know the doctors as well, you kind of know what the departments are like, and it's not like a massive hospital where you feel overwhelmed.
And you can just kind of make informal referrals. Yeah. You can start with,
I'm sorry mate, but my consultant's asked me to call you.
Consultant's right behind you.
Exactly.
Now when you did your foundation training, did you know you wanted to do GP?
It was something that was in the back of my mind. It was more that at that point I had ruled out certain options.
What did you rule out?
So, I ruled out psych. I never put it down, I just said it wasn't for me.
So why wasn't it for you, just very briefly?
A lot of the patients would have quite difficult backgrounds or difficult stories, and I would find that quite difficult to deal with for myself.
I can see that. I can, yeah.
Yeah, no, I am quite an emotional person, and so I found it really hard to deal with that, and I would really empathise with them and feel really sad, and I just thought that I think you're quite a stable person, and you're able to detach yourself but equally feel empathy, but I just feel I have a lot of feelings. Yeah. So yeah, I just couldn't detach myself enough. So psych I knew pretty early on, and the second one was surgery, which
again I can see that.
Again, yeah, just kind of the mentality, the intense work life. Yeah. Just knew that those two things weren't really for me. Then it was more between medicine and GP when I was doing my foundation training. I did an AMU job in my second year, so in F2. I actually really enjoyed it. And I think what I enjoyed the most was the general aspect of it. The fact that there was so much variety of cases when I was clerking people, but then I realised that it was the acute thing that wasn't really for me. The fact that, so then I was like, okay, so what? The only other thing that's general but less acute is GP. And then when I did my F2 placement, I was like, yeah, definitely this is what I want to do. I can imagine myself doing this.
GP is a very popular training program. So what are some of the advantages of A, GP training, and B, being a GP?
GP training itself, I think it is quite good to the trainees. So in a sense, a lot of the GP trainees have kids, and there's really ample opportunity to work less than full time. And I think in some of the other training programs, it's not that it's looked down upon, but it's not facilitated as much as GP training is. They really, in my group, there's loads of people who have either gotten pregnant during the time that I, have gone through training or already have kids. There's specific gaps in the rotas for less than full-time people. And so yeah, for that it's really, really good. And also in terms of the teaching, I know it varies from place to place, but in Stockport we have one afternoon per week for teaching, and on the whole they're quite good at making sure that we get away and have that time, a lot of the time, remember in F1 and F2 we'd be like, oh, I can't go to teaching, I'm too busy, the ward's busy or whatever, and you feel that pressure. But in GP training I've never felt that in Stockport anyway. I can't speak for the other places, but I've never really felt that. They will specifically say like, tell us if you're being, made to stay on the wards, because this is your time for teaching. It's a teaching program at the end of the day. So yeah,
I think every specialty has protected teaching time. It's just most specialties they don't care.
Like
even in medicine, you have time where you're meant to be protected. Just have time away from the ward. But if you're busy, they don't really mind. I remember I think it's changed now, but on medicine when I was in F1, the GP trainees on the medical rotation would always leave for their teaching.
Yeah.
Because if they didn't,
the hospital or wherever somebody in the hospital got in trouble.
Yeah.
But then the medical trainees on the same job, weekly missing their teaching.
Yeah.
And the worst part was, not only did no one get in trouble, the trainees got in trouble. Because they were like, oh, well, you missed your teaching, so now you're going to fail the LCP. It was just such an
Ridiculous,
odd
isn't it?
situation.
Yeah.
I think that has changed now. But yeah,
Yeah.
GP's good that they give you protected teaching time.
And they do, like I said in Stockport, they are pretty good at making sure that you do that.
Yeah.
In terms of, being a GP in itself, I think, I'm sure everyone has different reasons for doing it, but for me, like I mentioned before, the variety was a really big thing that I liked. I had been to clinics when I was a medical student where it would be like a cardiology clinic and it would be a heart failure clinic, and it just didn't appeal to me. I know for some people they like to be really knowledgeable in one area and be kind of the expert in that area, but for me I kind of like to see lots of different things, and I like seeing kids, I like seeing older people, I like seeing that variety. And so, like I said, between acute medicine and GP is kind of the only one where you see kids as well as everyone, so that really appealed to me, as well as the flexibility of the working. Being able to have a good work-life balance is really important to me, and having that kind of flexibility in terms of part-time, and also clinics, some places have kind of clinics that start a bit later or finish a bit earlier and things like that, as well as the fact that you can do other things. So as we said before, people doing minor ops or A&E or whatever it is.
So that's called GP with special interest.
Yeah.
So you can have so you can be a GP and then have like an interest in most things.
Yeah, like dermatology. A lot of women do with obs and gynae. So you can do lots of different things in it.
And correct me if I'm wrong. So if let's say you have special interest in, let's say, dermatology, I know some people who do things like that, and they go and do a derm clinic a week in hospital.
Yep.
So you can kind of go and be part of the derm team for a week, and then come back to GP and be a GP again.
Yeah.
Okay.
And that's why I think people like it so much, is because you do have that opportunity where you're not just in clinic day in, day out, and you have that thing to kind of break up the days. So I think there's so many advantages to doing GP. I think it is, like you said, a very popular program already, but we still need GPs, so.
What are some of the disadvantages of being a GP?
I think some people find the chronic side of it a bit frustrating at times. Sometimes you have a cohort of patients where you're not able to, help them, as it were, or you're seeing the same, you're seeing the same patients again and again, and you kind of feel like you're just trying to get through the 10 minutes and you're not really able to.
You're not going to cure them.
Yeah.
You're managing them.
Yes, and a lot of people don't like that side of things. Especially I can imagine people who go into things like surgery where you have that clear cut, you go in, you fix something, it's done.
Yeah.
To then have to go in and manage someone who has chronic pain or something like that must be quite frustrating.
Part of it's managing their expectations as well. It's not just managing the condition, it's managing what they believe can be done with it as well. One thing that I'd noticed about general practice, that I don't know, it could be a positive or a negative, I guess, is that it's quite consistent in your work. So you don't really have like peaks and troughs in terms of busyness. You're just kind of quite steady throughout the day, with like certain times you're doing more admin tasks and certain times obviously where you're seeing patients. Whereas in like hospital specialties, you'll have times where you're really, really busy, you don't even have time to think, you're just off your feet. And you have times where you can just chill and have a coffee and like not do anything for an hour or two. And you don't really get that in GP. You're kind of just consistently working.
I think you have peaks and troughs, but I think they're less up and down. So I think you do have fluctuations. For example, you'll have a day where you have loads of home visits and you have to try and split it between, whoever's around that day. And so your lunchtime will be really busy, but it won't be in the sense of you're either running around or you're sitting down. It'll be, you have a patient who's overrun, like it's kind of gone on, and then therefore you're running a bit late, and so you have to try and make up the time. So, there will still be ups and downs, but it might not necessarily be in the same way as hospital is. Now I'm getting to the end of my SC2 year, and I've got one more year left as an ST3, and then I'm just released into the wild. Like I just have to be a GP, and that's quite
scary, I bet.
Yeah, of course.
So tell us a bit about the GP application.
Obviously with COVID and things, I'm sure a lot of things have changed now. You had talked about doing the MSRA.
Yeah, I think we both had to do that, didn't we?
Yeah, so we had to do that for GP as well. And then based on, in my year, it was the top 10% of people didn't have to interview, and they could go straight through and basically get the job that they wanted.
Oh, right.
So if you came in top 10%,
Yeah.
would you just get your top choice automatically?
Yeah, I actually had to do the interview, but I don't think that's a bad thing. It's basically, because they've tested your clinical knowledge in the exam, the interview is just about communication skills. And obviously communication skills are so important as a GP.
Yeah.
So that's the main thing they're testing you on. They're not really testing you on whether you say the right thing, it's how you say it essentially.
There was a written part, right?
Yeah, so there was a written part as well, so I'm not sure if they're gonna keep this, but it was basically like the SJT.
Oh, okay.
But instead of having lots of different questions, it was one question, and you know how you have to rank the answers, you have to justify why you've ranked each one. So it's like a colleague comes in and they've drank alcohol and what would you do? Then for each one that you would do, you have to say why you do it. And then at the end, because we're GPs, we have to reflect on why we've done that.
My favourite thing about SJT questions though is the one that you like should not do.
Yeah.
There's always one option
Yeah.
that's like, so your friend comes in drunk, would you do A, like report them,
Yeah.
B, offer them support, or C, have a shot with them?
Yeah, exactly. It's like drink with them.
It's like, who's gonna pick that?
Yeah, I started my ST1 2 years ago.
Very good.
So how's it been?
So, why are you laughing?
I feel like every GP trainer I speak to says this. They're like, oh, buzzing to start GP, like I've got a GP, and then like, how's it going? Like,
you know why? It's because my first job was obs and gynae. As a female GP, I knew that it was important for me to do obs and gynae. You know, I mean, it just objectively is an important thing. And so I knew that I had to do it. I kind of prepared myself. I was like, this is gonna be difficult, but you've got to do this. It was more just like, it's such a new world. I turned up to obs and gynae and I was like, I don't know to do anything. They'd be like, all right, you're the SHO, off you go. I'm like, but now I'm so glad I did it and I definitely would recommend it. I think it's really important as a GP to do obs and gynae. It's obviously just something that once you get used to it,
it's fine.
It gets better, and then after that I did medicine, and you know, I mean everyone, GP trainee, you know, you're going to do medicine.
What did you do? What specialty?
I did Jerry's.
Okay, that's quite useful.
Yeah, Jerry's, which then became COVID.
So after your time on COVID wards, what did you do after that?
Then I actually got to do my GP placement of GP training. So that was my first placement of ST2. And I really, really liked it actually.
Was it what you expected or was it a bit different?
I think it was different because in F2 I was quite sheltered. I had a lot more responsibility, a lot more admin, a lot more understanding of how the practice was working. So it was a really good insight into it, but also I really enjoyed it. So that was really reassuring for me. It was quite a steep learning curve actually, because when I was in F2, I was only seeing new patients. So I think to develop my history taking, my tutor would only give me new patients. So funnily enough, I didn't actually see any chronic disease, which is like the whole thing of GP. That's most of GP. And so I didn't know how to manage things. Like I would put a plan in place and then I'd be like, sick of like cured everyone, because I'd never see them again. And then I came into F2, I came into SC2, and then people would be like, oh yeah, this didn't work. And I was like, so I actually saw a lot more chronic disease. I actually had to figure out, okay, if this doesn't work, then what do you do?
Well, that's the hard thing, isn't it? Like people come to you, most people can say, okay, this is the thing you need to do.
Yeah.
And then if it doesn't work,
then what?
Then what?
Yeah, and not only do you have to think of what to do next, but it's dealing with a patient who's frustrated because it's not working. Like it just brings a whole new level to it.
And part of being a good doctor, I guess, is not investigating things that don't need investigating.
Yeah.
You just don't need to scan everything or do a blood test for everything when it's not needed.
Yeah, exactly.
The number of times when I used to work in hospital, that patient would come to like a clinic, be like, oh, the GP's done like this and didn't work and that and didn't work, and I was like, that's exactly what I'm gonna do.
Yeah. One negative I will say is that different trusts work in different ways. So in Stockport, you don't have specific jobs that you need to do. You have a year and a half in hospital, and that could be literally any combination of jobs, and then you have a year and a half in GP. And I am going through my GP training without having done a paediatric job. Whereas I think previously it was, you'd have to do paediatrics, you'd have to do A&E, you'd have to do, you know, whatever, a certain number of jobs. And I think they should bring that back, because I think you need to know those things. I think not having those specific specialties, which are really important to GP, it makes it difficult. And then also I think what they're trying to do now is increase the amount of time you spend in GP. So now they're doing more what are called GP plus posts, where you do half your week in GP and half your week in, say, a hospice or something like that. And so you are actually spending more time in GP, and they're trying to promote that
Okay,
more.
that's good. Yeah.
So I think I agree that I think probably adding another year or so in GP would be better. The thing is with GP that you can do so many different things.
Yeah.
So there will be some people who do, you know, I know people who do a couple of days in A&E and then a couple of days in GP, or they have, you know, minor ops, so they do some small surgeries, things like that. So there is a lot of flexibility with GP.
Okay.
But for me, as a SC2 trainee, the way my week would work is I'd have one afternoon a week for GP teaching, and then the rest of the time I would be in clinic. So it'd be like 9 till 12ish usually, and then between 12 and 2 I'd have my lunchtime, but I'd have to usually do one or two.
You get 2 hour lunches.
Wait, you have to do 1 or 2 home visits, and a home visit is like, obviously you have to read up about the patient, make sure you, like, sometimes I would call them, especially if they were elderly, so they didn't have some random person like knocking on their door. I'd be like, oh, by the way, like, I'm gonna be turning up in like, you know, 10-15 minutes, so do all that stuff, prepare, go and actually see the patient, come back, write it up, potentially go and see another one. You know, it takes time to do all those things. Then you have your prescriptions that you need to sign off. So, you know, when people go online and order their repeat prescriptions, that's me. I'm going, yeah, tick, tick, tick. I have to go in.
So how many do you have to do in a day, roughly?
About between 30 to 50.
50?
Oh, that's
Yeah.
low.
5-0.
I think I was like 5.
Yeah, I thought you were like 10, you know what I mean?
No, because it depends on, some of them are really easy repeat prescriptions that are just like, oh, like nasal spray or whatever, that's fine. But some of them are more detailed ones where you then have to go and check, like, do these people need to be seen by the GP as well?
Is there an interaction? Or
Yeah,
like,
is there interaction? Do they need like a blood pressure checking? Like all those kind of things.
Okay.
So then I have to organise those, and then you have to go through your letters. So whenever people get seen in secondary care, they'll have a letter.
GP to review.
GP to arrange.
So discharge summary, GP to check U's and E's in 2 weeks. That's what I have to do. On urology, we should say GP to check U's and E's in 1 week. 1 week.
How's that gonna
You've
happen?
literally just discharged the patient. How am I supposed to get them checked in 1 week? Yeah, so anyway, so I have to do all those things, go through all those letters, sometimes call the patient. So that 2 hours, it goes by really, really quickly. And then you're doing your afternoon clinic.
Any advice you'd give to budding, up-and-coming GPs?
Up and coming GPs, I'd say whenever you're doing any jobs in hospital or in any specialties, try and find ways to link it back to GP. That's a really, really big thing, I think, is try not to just think, oh, I just need to get through the 6 months and then I'm done. Try and think of ways that you can actually, you know, apply it when you're doing GP.
Well, thank you, Akshara, for coming on our show and obviously imparting all your knowledge to our many viewers. If you guys have any questions for Akshara, we'll leave her number in the description box below, so you can just send her a text and get in contact.
Or
whenever you
we'll
need.
link her Instagram, just slide in the DMs.
Yeah.
She loves that. You want to do friendship?
I have enough of those creepy messages, okay, I don't need any more.
Anyway, so we're going to film a few more medical journey episodes. We've got them planned.
Yep.
So watch out for them in the next few weeks. And apart from that, we'll see you guys again next week.
Yeah. See you later.
Do I get to be on next week too?
No.